So my talk today is about adverse drug events and the risk posed to our patients by polypharmacy and what we might do to perhaps improve patient safety by deprescribing. So rather than trying to keep prescribing and not stuff it up with errors, just try and reduce the amount of prescribing we do. And I'm going to illustrate this problem using a patient example from my practice. It was quite a long time ago that this happened now, but it's stuck in my mind, and I think it illustrates quite well some of the problems that we're facing. So Mrs. F, she's a lovely lady. She was 76 at the time, and she went to visit her daughter out of town and suffered transient, distorted, flickering vision of her left eye, which concerned her, and so she went off to see the doctor in the weekend. The doctor did a blood test and found she had an ESR of 90, which is elevated, obviously, and he wondered about whether she had giant cell arteritis, and so started her on prednisone and referred her to the rheumatology service and for a temporal artery biopsy. So 6 weeks later, she got her rheumatology appointment, and systems error, perhaps, quite a long time to wait. At the time, she was noted to be feeling very poorly with a cough, and in fact was quite tearful. So she complained of fatigue, malaise, she felt weak, she felt lightheaded or dizzy, she had a productive cough, and she was tearful. Her husband had recently died, so who knows whether that's a symptom of what? Life? She didn't have any headache, jaw claudication, or symptoms of polymyalgia rheumatica. On examination, she had low blood pressure, 110/80. She was afebrile, chest was clear, and sometimes some query about whether her muscles were a little bit weak, but then she's an elderly lady, she's supposed to be a little bit weak. At the time, she was on 8 medications, so she was still taking prednisone, down to 40 milligrams now, and she'd recently finished a course of antibiotics for her chesty cough that I'd obviously given her. And she was on 6 other regular medications: propranolol, spironolactone, furosemide, potassium thyroxine, and salbutamol. Anyway, the rheumatologist took pity on her and decided to admit her to hospital, mainly because she was emotionally labile and unwell and has multiple problems that need sorting out. So he wasn't quite sure what was going on, but felt something was going on and that the best place for her was in hospital. During her admission, she was seen by the rheumatology, respiratory, cardiology, gastroenterology, and neurology teams, and she was subjected to a cascade of investigations and treatment. These were most of her investigations: temporal artery biopsy, chest x-ray, sputum culture, pulmonary function tests, ECG, 24-hour Holter monitor, echocardiogram, ventilation perfusion scan, electromyogram, lumbar, hip and knee x-rays, and various blood tests, all of which were normal. So on the ward, she wasn't feeling all that well and she fainted. Someone thought maybe she had a PE or was it an arrhythmia, they weren't quite sure, so they thought start heparin, just in case. And then she suffered hematemesis and melena. A gastroscopy revealed bleeding gastric ulcer, so they stopped the heparin, gave her a blood transfusion and started her on omeprazole. When the neurologists saw her, they wondered whether she might have steroid-induced proximal myopathy. And so that was some weeks into the admission, and the first sort of thought that maybe it was adverse drug effects that causing her problems. So her medications were withdrawn slowly, and she was discharged home 1 month after admission, following what was described in the notes as a stormy course. And she vowed never to go back to hospital. And she lived a further 15 years, having kept her word, so she never actually went back to hospital again and died sometime later. So this is obviously an example of adverse drug events. She had a host of side effects from the prednisone that she was on, and she was also on a couple of antihypertensives that was giving her low blood pressure, postural hypotension. So adverse drug events are a common cause of avoidable hospital admissions in the elderly. It's estimated that they cause up to 6.5% of unplanned hospital admissions. So that's a lot of suffering in our patients and also a lot of money to the health system. And if you just look at one window onto patient safety incidents is New Zealand's treatment injury accident compensation claims. And these are the accepted claims, so these are the injuries. ACC has decided these are injuries and the cause of injuries for primary care treatment and for older patients. And you can see medication is the leading cause of injury, causing around about 1/3 of the treatment injuries and most of the serious and sentinel injuries. Those are the red ones at the top of that bar on the left there. So the adverse drug events may be vague and non-specific, and so we're missing a lot of them, I think. They can present as falls, delirium, all sorts of sort of vague things that could be something else. And so if you think of Mrs. F, she had these vague, non-specific symptoms like fatigue, malaise, tearfulness, weakness, cough, postural hypotension. Obviously the ulcer and hemorrhage maybe was a bit more obvious, but not easily recognised necessarily and perhaps easily overlooked. So the drugs causing most harm are those that are most commonly prescribed with well-recognised benefits in most patients. So these include the antibiotics, anticoagulants, hypoglycemic agents and cardiovascular drugs. If you look at the medication injuries in the ACC claims data set, so these are just the injuries caused by medications. You can see the antibiotics by far and away the leading cause of medication treatment injuries that result in claims. Followed by anti-inflammatory drugs, ACE inhibitors, warfarin and prednisone in there. Obviously, we're missing a lot of the drugs, medication injuries as well, but that's at least one perspective on the drugs that are causing the injuries. And so thinking about the risk factors for adverse drug events, it's not just error. People doing the wrong thing or the system's not quite being there or whatever. The single greatest predictor of an adverse drug event is the number of medications a patient is taking. So in the elderly, one estimate puts it at 38% risk for 4 medications and 82% if you're taking 7 or more medications. So Mrs. F, she was on 8 medications shortly before she was admitted to hospital. So quite a high risk of suffering an adverse drug event. This isn't Mrs. F, but could well have been. She was a little bit rounder than that, but you can see the struggle with taking 8 different medications, trying to carry them home, not easy. So polypharmacy is defined in various ways, but we can think of it as just taking lots of medications. It's common in the elderly, and it's becoming more common as people are living longer with more chronic conditions. In New Zealand, it's estimated that around about 10% of adults 65 years and older are taking 10 or more regular medications, and many of these medications are thought to be potentially inappropriate, where the potential risks outweigh the potential benefits. So how have we come to this? You give one drug and then you give another drug to sort of counteract the side effects of that drug, and you're always trying to sort of balance the potential risks and the potential benefits. So one of the drivers of polypharmacy is patient demand, I think, with direct-to-consumer advertising and the medicalisation of life. Ask your doctor if taking a pill to solve all your problems is right for you, I think is a little bit of a message that people are getting, and wish there was. I wish there was too. But also, I think the disease-specific guidelines are problematic. They're telling us when to start drugs, but not when to stop them. And the information that they're based on was often on research in younger patients with single conditions, rather than a lot of our older patients who've got lots of different conditions requiring lots of different guidelines. Multiple prescribers is also associated with polypharmacy. and uncertainty and fear, I think, is in the part of doctors is also driving over-treatment, over-investigation, polypharmacy. And so, how does that work? Medicine is a practice in uncertainty. As doctors, we're making decisions about our patients and what we should do. If somebody turns up with transient flickering vision and has got an ESR of 90, we're not sure, but we need to take action. And when we take action, we need to take responsibility in this sort of mire of uncertainty. So Fox was a woman who studied uncertainty in the 1950s, a long time ago, and she classified 3 types of uncertainty in medicine. So there's the uncertainty and the incomplete mastery of the available knowledge, which means we do know the answers to these questions, but I personally don't know that answer. There's also the limitations of current medical knowledge. So at the moment, we actually don't know what the best thing to do with our elderly patients is, because we don't have the research in elderly patients. And there's also the uncertainty or difficulty in distinguishing between those 2 types of uncertainty. But the fact that we must act before certainty can be established, if it ever can be, makes clinical medicine not a rational science nor an art, but a practice. And uncertainty provokes fear. I hear some people don't feel that fear, but I know I do. There's both the patients feel fear, and the corporates know this, and they market, diseases to the patients, trying to create, more of a market. And uncertainty in doctors provokes fear in us. So patients cope with their fear by going to see the doctor and seeking our advice and reassurance. And doctors, we cope with our fear by trying to reduce the responsibility or trying to reduce the uncertainty. So we can reduce the responsibility by referring patients. So Mrs. F, she was referred. Deferring to guidelines and protocols. If you're not quite sure what to do, you look it up and do what that says. Or sometimes we can even try the strategy of abandoning the patient, making them make the decision or letting them make the decision, even if we might think it's the wrong decision. And we can try to reduce the uncertainty, and I think this is what's partly driving over-investigation and over-treatment. We're doing things just in case, because we're more likely to get criticised for missing something than for doing something. We can also try and reduce the uncertainty by developing special interests, or by the time-honoured technique of denial and self-deception, which I like. So I think there might be a little circle of harm. The patient presents, it's chaos. We have to try and work out what's going on, what's important, what's not important. We have to try and work out what to do in uncertainty. We're not sure. That the uncertainty provokes fear in us. We want to do lots of investigations and lots of treatments because we're terrified of missing something. The treatments that we subject our patients to, if we do too much, can produce harm, and that causes more vague, non-specific symptoms, more chaos, and then there's more uncertainty, and around you go. So breaking the cycle by deprescribing, swimming against the tide. So instead of ordering more investigations, prescribing more drugs just in case, we need to try and sit tight and try perhaps withdrawing medication as a therapeutic option, rather than just adding in another drug to counter the effects of the previous drug. So deprescribing is the process of tapering and stopping medications. Best to deprescribe the potentially inappropriate medications. And deprescribing is an integral part of good prescribing practice. It's about providing the best care and improving patient outcomes, trying to reduce patient harm. It's not about abandoning patients to save money. It doesn't mean we don't love our patients anymore if we want to withdraw some drugs from them. So there are lots of barriers to deprescribing. I think firstly, there's a lack of appreciation of the extent of polypharmacy-related harm. And, we're more worried about what harm the disease or the problem can do. We're not so aware of the problems caused by the things that we do trying to help people. There's also difficulty not knowing what drug to stop when and how. If people have sort of ended up on 8 medications that they've collected over the years, following various guidelines, starting an antihypertensive here and a bit of an aspirin there and a statin there and, an hypoglycemic there, it's difficult to recognise the tipping point when a medication that was once appropriate has become inappropriate. Doctors might also fear upsetting their patient and also fear adverse consequences and criticism. So again, if you withdraw the aspirin and the next day your patient has a stroke, you feel pretty bad about that. But if you leave them on the aspirin, there's a risk they'll fall and bleed as well. Maybe you'll feel bad about that, but it's perhaps not quite so bad. And we're also got a little bit of professional etiquette going on. We're reluctant to stop drugs that our colleagues have started sometimes. There's a lack of an incentive for us to deprescribe, and there's a perceived lack of time, I think, in practice as well. Easier just to write the 3-monthly repeat than to think, is it time to start talking about withdrawing this medication? So, in conclusion, how am I doing?
Fine.
To try and improve patient safety, and reduce our adverse drug events, we need to start looking at addressing the risk factors for adverse drug events, which is not just us making errors or the patient making errors or somebody making an error. It's also just looking at trying to reduce the number of drugs that somebody's on or reducing their exposure to risk. And we need to remember that trial of withdrawal of medication is a therapeutic option. It's just as good as trying adding a medication, or it may be. And there comes a time for deprescribing or swimming against the tide. Unless that is we can turn the tide, which is probably problematic, I think, in a direct-to-consumer advertising environment. Okay, thank you.